Hello, my name is Janet Crane. I'm from Johns Hopkins University, and I'd like to thank the organizers for giving me the opportunity to talk to you about clinical biomarkers and assessment of bone disease and response in complex lymphatic anomalies. I have nothing to disclose. I will talk about off-label use briefly of bone medications, including bisphosphonates and denosumab, and I have received grant funding from the National Institutes of Health. As you guys are well aware, you've heard over the conference in the last day and a half, there are multiple bone phenotypes that can occur with CLAs. To orient everyone when we're talking about bone, I've shown some pictures here on this slide. So first I'll direct you to the femur, this cross section of the femur. You can see the cortical bone, which is the dense bone that gives it its strength, and the transverse section of it as well. And then the oddly shaped ends of the bone, you can see this interwoven bone that's described as either medullary or trabecular bone. The bone is a well vascularized organ. You can see the cartoon picture of the arteries and veins that supply the nutrients and oxygen to the bone, and the cross-sectional areas just to show you how dense the vessel supply really is in the bone. This is a mouse bone of a longitudinal section, staining for the blood vessels, zooming in on the growth plate and zooming in on the medullary cavity. And so in CLA, depending on the type of CLA, you'll see specific types of bone that are being targeted. In Gorham-Stout disease, it's more likely to be cortical bone loss. In GLA and Kaposiform lymphangiomatosis, you're more likely to see medullary/trabecular bone loss. In CCLA, you'll see lymphatic channels appearing abnormally within the bone. This becomes important because those are sites that you'll want to monitor more closely. And so when you're choosing an agent, it's unknown at this point what agent we should be using, the doses, the durations. We're all still in the hypothetical phase and trial by error. And when choosing an agent, the things that run through my mind and questions that I talked to my vascular colleagues about with the specific CLAs. If we think that the signal is coming originally from a lymphatic endothelial cell and causing the signaling the osteoclast to erroneously resorb bone, then we probably just need to target an agent that will kill off those osteoclasts. So bisphosphonates seem like a very reasonable option as they poison the osteoclasts and cause apoptosis or cell death. Examples of specific bisphosphonates would be pamidronate or zoledronate. A second hypothesis is that osteoclast could be secreting a factor that's then recruiting abnormal lymph growth into the bone. If osteoclasts are sending out this signal, we might want to interrupt them sooner in life before they start resorbing bone. In that case, we would turn to an agent such as denosumab, and we'll explain how these drugs work. The third hypothesis is that it's activation of the RAS-PI3 kinase mTOR that's overactivating the lymphatic malformation, and the bone is just an innocent bystander. In this case, you would want to get the benefits of how bisphosphonates work by inhibiting this pathway, but perhaps want less of it to actually get deposited into the bone and causing possible skeletal side effects. And so how do these drugs work? So we're talking all about bone resorption, and that's done by a cell called the osteoclast. The osteoclast is derived from hematopoietic stem cells and receives multiple signals from other cells in the bone that stimulate its differentiation, proliferation, and fusion to become these giant multinucleated osteoclasts. Bisphosphonates, as I said, cause apoptosis of the mature osteoclast, whereas denosumab is a monoclonal antibody that binds to rank ligand, rendering it inactive. Therefore, these mononuclear cells cannot go down the differentiation pathway, and you don't get any of the signals that any of these precursor cells might be signaling out, nor the bone resorption. Here's an example of some radiographic biomarkers that we've followed. DEXA is a way to measure bone mineral density. In children, we look at different sites, including the spine, total body, less head, and total hip. In this particular patient who had KLA, his height-adjusted Z-score, so Z-score is a statistical representation of of how many standard deviations one is away from average. So 50th percentile is 0, 3rd percentile is -2, 97th percentile is +2. At baseline, 6 months prior to diagnosis and initiation of treatment with cylindronate, his spine, total body less head, and total hip height-adjusted Z-scores were low. Over the course of the years of treatment that we've done, initially quite aggressive with once-a-month dosing, and then spaced out to 3 months and 6 months and eventually a year, his bone mineral density has increased, as we can't particularly target the bisphosphonate to the affected bone, but it does have total skeletal effects. So things that we've been monitoring for him, and you can see pictures of how they scan the hip and the spine. One of the side effects of bisphosphonates is that they get, and for denosumab too, is they get deposited at the sites of most rapid areas of growth in children. This is in the growth plate, and you can see the deposition where it's causing dense bone. So this newly formed bone hasn't been able to resorb and reshape like normal, so you get this thick sclerotic line. You can see this in the radius of the wrists. You can see it a little bit in the phalanges and the fingers. Becomes more prominent after 2.5 years. So he's now been on cylindronate 2.5 years. He's grown in that interim. So that sclerotic band looks like it's expanded. That just represents the bone, how much bone has grown in the last 2.5 years. And it becomes more prominent in the phalanges of the fingers. Now, 4.5 years later, he's starting to have his pubertal growth spurt. It's been over a year since his last infusion, and that sclerotic bands are starting to separate from each other and becoming lighter and getting a little bit resorbed. One of the complications that was seen early with overtreatment with bisphosphonates is called an Erlenmeyer flask deformation, and that's because too much bone resorption was being inhibited and the bone couldn't reshape to its normal shape. Biochemical biomarkers are also of importance and something to consider when monitoring response to treatment. So before we get into examples of some biochemical markers, I thought I would review the signaling that happens in bone. Normally, you have osteocytes that are these cells in the bone that are the mechanoreceptors, and they sort of survey and watch out what's going on in the bone and send signals. So if there's a microfracture or a major fracture or the bone just seems weak, the osteocytes will send out a signal. That signal is rankliginin in CSF, which we had talked about how it affects the monocyte lineage to differentiate into osteoclasts. Some of the things that our lab particularly has studied is the cytokines and growth factors that get secreted during this process. So pre-osteoclasts, before they form into osteoclasts, secrete a factor. And one of their factors that they secrete is platelet-derived growth factor type BB. That works by recruiting endothelial precursor cells and mesenchymal stem cells to bring in blood vessels and cells that can differentiate into osteoblasts to the bone remodeling site. While osteoclasts are resorbing bone, they break down the protein in the bone, which is collagen, and those byproducts of collagen breakdown can be measured in the circulation: CTX, NTX, DPYR, PDY, HIP, and TRAPZ5B. In the bone matrix, there are also growth factors that are inactive. When the bone is resorbed, those growth factors get activated and released into the bone marrow microenvironment and can also stimulate cells. One of the factors called transforming growth factor beta type 1 stimulates mesenchymal stem cells to move closer to the bone resorption site. A second factor called insulin-like growth factor type 1 then causes differentiating of those MSCs into the osteoblasts. The osteoblasts are then able to make bone. While they're making bone, they secrete different factors that help them mineralize the bone and build the protein in the bone. So the type 1 collagen is synthesized as a procollagen and gets cleaved. So the pro products, both the N-terminal and C-terminal, can be found in the circulation and can be a marker of bone formation. Bone-specific alkaline phosphatase and osteocalcin are important for the mineralization of the bone and can be measured. So in my patient, we measured CT-low peptide, or CTX, as a bone resorption marker, and osteocalcin as the bone formation marker. Before treatment, his levels of CTX were fairly elevated. as you expect in a child. And when we gave bisphosphonates, which then kill the osteoclast and stop bone resorption, you could see a rapid decline in the CTX. It did rebound fairly quickly, and we did use this as a marker to help reassure us on the frequency in which we were treating and making sure we weren't going to freeze his bones and over-treat him. And we were able to follow this over time. Whenever you inhibit bone resorption, you can interfere with that bone coupling process and then also potentially inhibit bone formation. That's important if you have a syndrome like in the CLAs where you have osteolysis. You do eventually want the bone to form. And so keeping an eye on the amount of bone formation that's going on and recognizing that we do need to allow some bone resorption to occur so bone can fill in. I have lots of other thoughts I'd like to share, but I'd like to stick to time. So I'd like to say thank you for listening in, and I look forward to hearing your comments and taking any questions. Thank you.